Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. So again, welcome to today's program, Palliative Care in 2025. I'm Katie Armsby with Cancer Support Community Atlanta. If this is your first time joining a Cancer Support Community Atlanta program, we welcome you and we invite you to visit our website, cscatlanta.org. There you can see a complete list of all the virtual and in-person oncology programs that are available. I'm going to highlight just a couple of them. We do have a support group that meets, that's virtually and in person, led by mental health professionals, so those are available to you. We have great nutrition seminars that are offered monthly. We actually have a few nutrition seminars offered monthly. We have stress reduction classes like yoga and Tai Chi. Some really fun cooking demonstrations. If you can get to us here in Atlanta and Sandy Springs, we invite you to join us for those fun cooking demonstrations. And then, of course, education programs like these. So our website is highlighted there, cscatlanta.org, where you can see a complete list of everything that's available, again, virtually and in person. So I'm excited to welcome today's program moderator, Dr. Dutcher.
Hello.
Dr. Giselle Dutcher is a board-certified physician in medical oncology and internal medicine with extensive training across the U.S. She's passionate about helping patients navigate the many complexities of cancer treatment and believes in a collaborative approach to care. Originally from East Cobb, Dr. Dutcher is excited to return to North Atlanta to serve her home community. In her free time, she enjoys exploring local coffee shops, bookstores, and nature trails. She practices with Georgia Cancer Specialists at their Sandy Springs location and coming locations. So with that, Dr. Dr. Dutcher, I will pass it off to you to get us started.
Hi. So welcome everyone. My name's Dr. Dutcher. I'm, as the bio said, I grew up in East Cobb, but I spent time elsewhere in other parts of the country for my training. And so I'm definitely glad to be back home and the place where I grew up. And so happy to have been here with Northside for 3 months, 3 months as of last week. And so it's really great to be doing this. I think one of the great programs that Northside has, and with the support of the Atlanta Cancer Support Community, is that all patients who are at Northside really have access to this great support, because we know that there's so much that goes into caring for patients with cancer, living through cancer, more so than just the chemotherapy itself or whatever treatment people may be going through. And a question that I get a lot of times is, well, how do we, what happens other than chemo, and who's going to help out with, managing symptoms and managing our concerns? And that's where our support from not just the cancer support community, but also from our colleagues like Dr. Gill with Palliative Care can be really helpful, because Dr. Gill and colleagues in Palliative Care are, trained physicians and trained clinicians who are, they know all about the medical things that you're going through, but they also know about, and they have specific training to help you with the concerns and symptoms that are unique to people going through their cancer treatment. So, am I supposed to introduce Dr. Gill? I will just say as a brief introduction that as you're seeing on the screen, he's dual board certified in internal medicine and hospice and palliative care medicine, which are not the same thing, and he'll explain further. He completed internal medicine residency at Staten Island Hospital, and where he had a passion for supporting both patients and their families. He did his fellowship in hospice and palliative medicine at MedStar in Washington Hospital in DC. And he has been working in Georgia for many years. He was running a community palliative care program in North Georgia, and now is practicing it with PalliPain, his own practice. So we're happy to partner with Dr. Gill.
Thanks, Dr. Dutcher. I appreciate that. Um, so yes, hi everyone. My name is Zameer Gill. I'm a palliative care physician, and I have been a palliative care physician for about 12 years in the Georgia area. And I'm really here because I love to give presentations and talk about palliative care and kind of what it is, what it isn't, how we can help patients, kind of dispel some myths about palliative care and things that I've heard of over the years. So, yeah, I think we'll jump into it. Now, just going to start with a little bit about me. I live up in the Beaufort area. I've got three little kids and a lovely wife who also works at Northside. And I've thrown in a few pictures just for entertainment purposes of our trip to Orlando about a year ago for spring break. But it was a good trip. You'll be seeing a few more pictures from here in a few minutes. So, what is palliative care? There's a World Health Organization definition that describes palliative care as an approach that improves the quality of life of patients and families who are associated with problems associated with life-threatening illnesses. That is a very broad category, and it's also very vague at the same time. So the easiest way to think of palliative care's goal is to improve quality of life for any patient suffering from severe illnesses. Um, we offer a wide variety of support, whether it's symptom support, psychosocial support, spiritual support. Um, we offer a wide variety of ways that we can help, but a lot of times it's a lot easier to talk about palliative care by giving an example. And so the easy example that I can give that is of a lot of patients that I see is if we have a patient who was recently diagnosed with cancer and they've had a resection or a biopsy already done. They are planning to start or have started chemotherapy, radiation therapy. And we all know that chemotherapy can take a toll on your body. We know radiation therapy can take a toll on your body. So that's where palliative care can help. Our goal is helping with the symptoms. So while someone is still getting that chemotherapy, the radiation therapy, we help with things like nausea, vomiting, fatigue, pain. We have social workers that help with psychosocial support. We have chaplains that we work with that can help with spiritual support. So it's kind of a multidisciplinary team that helps manage someone's quality of life. Now, by extending that definition a little bit, we also help families because we understand that families are caregivers, and caregivers go through a lot taking care of someone with family. So we also figure out ways that we can help those caregivers as best we can and provide them the support that they sometimes may not get. So how does that compare to hospice? I can tell you, I get asked this question about twice a day on what is the difference with hospice and palliative care. Doesn't hospice do all of that? Sort of. So you can look at it as hospice is a portion of palliative care. Up until 2007, they were actually one and the same. And in 2007, when the two fields kind of started verging apart in a lot of places. But the biggest difference that we see between palliative care and hospice care is both of them focus on physical and psychosocial relief. Both of them focus on quality of life. Both of them use a multidisciplinary approach. The difference with palliative care, though, is palliative care is appropriate at any stage of someone's disease. And it can be given at the same time as curative treatments, whereas hospice care is generally limited for patients who have a prognosis of 6 months or less, and most of the time excludes advanced aggressive therapies. The easy way to think of that is I see patients in my clinic who are in their 20s and have cancer, and they have significant symptoms from their chemotherapy, but the intent of that chemotherapy is curative. And So my goal is to help them with that nausea, the vomiting, the pain, the fatigue, all those other symptoms while they're getting those treatments. And then once they get to a point where they don't have any evidence of disease or they're or cured, we say goodbye and we go our separate ways. And I say, if you ever need me again, I'm here to help. So that's the big difference between the two. And it's a way for us to all know you can do both. Just because you see palliative care doesn't mean that you can't have the treatments that are appropriate. And so these are just different ways of saying that. Years ago, like I said, they were the same thing, and then they've just started verging apart. When we see patients now in palliative care, I do like to try and see patients as early as possible in their diagnosis so that I can get to know them, so that I can get to know what's going on with them, get to know how they're doing. And they may not have a whole lot of symptoms early on. That's okay. That just means, hey, you're doing great right now. You're managing the treatments okay right now. Here is my number. If you don't feel good, call me. If things are not, if you're feeling sick, you're feeling tired, if those symptoms are starting to come up, at least people have a person they can call and say, hey, I think I need some extra support here. So why do we have it? Why has palliative care become a thing? It's something that one of my attendings told me a very long time ago, and that is, as medicine has evolved and has changed, medication treatments they've changed the way we live, they changed how we get sick, and they've changed how we die. One of the things that he told me is, or one of the things that I was told by one of my attendings a long time ago, was medicine has become so advanced in the last 50 years that we have forgotten how to die. It couldn't be any more true as we progress with these treatments. So we know that calling or being seen by palliative care early on can help someone's quality of life. We know that it can improve survival. There have been studies on this that patients have actually lived longer if they received early palliative care because their symptoms are well controlled. They feel better. They get more treatments over time because they're able to tolerate those treatments for a lot longer. And so we know that it improves the patient's compliance. It reduces hospitalizations, leads to greater patient satisfaction. So it is meant to be a support for patients who are already going through a lot. So who do we see? So chronic illnesses. I use cancer as the big example because of the audience that is here today. But any chronic illness, really. It's whether we're looking at heart failure, cirrhosis, ALS, Alzheimer's, dementia. A lot of them have symptoms that we can help try and manage. A lot of them have that caregiver support that sometimes those caregivers need in saying, this is what's going on. Is this normal? Is this what we're supposed to be seeing? So it is any chronic illness or any significant illness that someone's potentially going to live with for the rest of their lives. So we generally look at 3 different categories for support, or I do at least. I look at pain as the very first symptom that I look at because we use a screening tool called the ESAS, which lists things like pain, nausea, vomiting, fatigue, sleep, appetite, constipation, all these symptoms that you can have from being on these treatments. But if you think about it, pain is always going to be that top category because if you're hurting, you're not going to sleep well. If you're hurting, your appetite's not going to be there. If you're hurting, you're going to be fatigued. Pain should always be one of those things that we can address because it's something that we can treat. Once we've talked about pain a little bit, then we can look at other symptoms. We can look at things like the nausea, vomiting, anxiety, agitation, delirium, shortness of breath, stuff like that. That is generally my portion of it. I'm a physician. Those are the medications that I know I can help treat with. The emotional and spiritual support, I can do a little bit, but I trust other people to be a whole lot better at this than I am. That's why it's a team. So we use a team of LCSWs or psychos or social workers, um, counseling support, stuff like that, people like that to help with that psychosocial aspect, which we'll talk about in a minute. But it always starts with pain, right? We have to deal with or figure out what is it that's hurting, how is it hurting, and we do that by doing an assessment of the patient and what is causing their pain and what type of pain is it. There's multiple different types of pain, whether it's pain, somatic pain related to soft tissue or bone injury, whether it's visceral pain, which is more related to organ damage, whether it's neuropathic pain related to nerve damage. We want to do a good assessment of patients to understand what's causing their pain and what is the right medication that targets those things as best we can. And there's lots of different assessment tools. So we have 0 to 10 that I'm sure a lot of patients get asked with every hospitalization, ER visit, physician visit, urgent care visit. We do 1 to 10. We have the Wong-Baker scale, which is more of how someone looks. If you're smiling, it's a 0. If you're frowning and look like you're in tears and curled up on the ground, that's a 5. We have other scales ranging from excellent to poor. And so there's a lot of different tools that we use for pain. There's nonverbal pain scores where we can assess patients who are nonverbal and try and understand what's causing their pain and how they're feeling. Everyone's pain score is going to be different. A 5 for one person is a very different 5 for another person, and is very different a 5 from the third person. And so a lot of these pain scores are very specific to the patient that's giving us these numbers. And they are fantastic for us in helping us gauge how our treatments are working over a course of time for that same patient. Shortness of breath we see a lot of shortness of breath with cancers related to the lungs. And so there's a lot of different treatments that we can do for shortness of breath. Whether it's cancer, whether it's COPD, whatever the causes can be for that shortness of breath symptom, there's treatments available for it. We work together with our oncology partners. We work together with our pulmonology partners. We work in conjunction with other physicians to say, let's make sure that we are medically treating this condition as best we can. And then depending on what the symptom is remaining after all those great treatments, how can we help with those symptoms? The last thing that I want to do is treat shortness of breath masking something that's serious that's going on. So that's why we work in conjunction with other physicians and saying, hey, this person is in our office. They are way more short of breath than they've ever been. Well, that's abnormal for this person. Let's talk to the other physicians and let's do a workup first before we just try and treat a symptom. Nausea and vomiting. So very common symptom, I would say, for patients with cancer on treatment, depending on the treatments that they're on and the emetic potential for those drugs. There are some drugs that have a very high likelihood of making you feel miserable, and there's some drugs that are lower. So we look at nausea and vomiting based on what causes it. Now, I'm going to say something really weird, and it's going to make some people laugh, but I can't see you since I'm on video. But nausea and vomiting is actually my favorite symptom. And that sounds really weird to say, but it really is, because when we look at slides like this, we can understand that nausea and vomiting does not have one cause, which means it does not have one treatment. There are so many things that can cause nausea and vomiting for our patients that can all be related to any of their chronic conditions, including cancer. And just like there are so many ways or reasons for that nausea and vomiting, there's a lot of treatments for nausea and vomiting. So just because one thing doesn't work, well, we've got a whole toolbox to help treat that nausea and vomiting. But the first step of that has to be understanding what is the cause. If we know what the cause is, we know the right medications that we can try on it. So that's a quick example of just some symptoms that we like to try and manage. There's a whole lot more, whether it's anxiety, depression, sleep. All of these are things that can affect someone's quality of life and make them not quite feel like themselves. We then look at the social aspects of care. We look at the patient's support network, financial barriers, access to care. I think over the years, we start to see people that we unfortunately label as non-compliant. They're not non-compliant. They have other aspects to their care that they just couldn't make it to their appointment. They just can't do it because of one of these barriers. And I think it is really important to sit down and try and understand what are those barriers before we unfairly label a patient as non-compliant. So this involves regular meetings with the patient and family so that we can understand what are their more into their social lives. We can look at social care plans that can come from those meetings to help us figure out what are the patient's values and goals and preferences, and how can we help get them to more of those treatments if that's what our goal is. We do utilize family meetings quite often. I tell people all the time, I love a good family meeting. You throw more people in a room and you get a few of them to start yelling at me, and it was a great meeting. We will get through what we need to get through, but it's getting through those emotions first is always important, as long as nobody throws anything at me. I'm not very fast. I can't duck anymore. So if no one's throwing anything at me, put me in a family meeting any day of the week. But we have to understand what worries our patients too. That's a big part of social determinants of health. It's a big part of the social aspects of care. So is it financial, or is that a big concern for them? Because it absolutely can be. Children, child care. There's so many different aspects to the involvement of children, whether they're young children or older children. How do we have these conversations? How do we care for them? If we have a patient that has young children, how do we help with them getting care during the day while someone's at chemotherapy during the day? So there are things that our patients worry about that we would never know unless we asked. Paperwork is a big worry. The amount of paperwork that we get to have to fill out for medications, for treatments, for therapies, for physical therapy, the chemotherapy, whatever it is, there's a lot of paperwork. So there are a lot of things that can cause worry, and a lot of times it's unexpected. I don't think my daughter expected to have to worry about a velociraptor trying to eat her during our spring break vacation. So anything can cause worry. We just got to sit down and talk about it. And then we look at the spiritual aspects of our care. Spirituality is it's a fundamental aspect of palliative care, right? We have to understand our patients and what they feel is their meaning, their purpose. What are their true beliefs and values? And how does that correlate with the treatment plans that we are putting forward to them? Now, that is where we ask for chaplaincy support. I've worked with quite a few chaplains over the years, and there are some fantastic chaplains, non-denominational chaplains that can really sit down and talk about spirituality. It is a different aspect than, again, just like social determinants, we don't know until we ask. Cultural aspects. That goes right back to the social determinants, and what do we feel like our population looks like? What are barriers or prejudices that we might have against certain populations? We have to take that time to help understand those. Whether we're working to utilize the right language, the right translation services, How do we help support minority populations? We have to take the time to understand that, because not every treatment plan is the right plan exactly the way we want it to be for everybody. And we can't forget our families. Providing support for someone who has an advanced illness, it can be exhausting. And families, a lot of family members or caregivers will tell you that they have to put on a strong face as long as they can. And we know that. We know that these people are putting in all of their effort to take care of their loved ones. How do we support them? How do we give them the help that they need? So it is always very important to have family members present at these meetings to help understand what can we do from a bigger picture. Okay, let's see if this will play. No. All right. I can put that link in the chat box for everybody to take a look at. So in summary, our goal for palliative care is to relieve suffering. It's helping patients that have serious illnesses with managing their symptoms, understanding what treatment options they have, understanding what options they have, not even treatment options, and helping them make complex decisions. We help in a wide variety of ways. We also help with advanced directives and completing your advanced directives, which is very important. And the rate of advanced directive completion in the state of Georgia is poor. So we help with completing those advanced directives, as well as helping patients understand sometimes they've filled things out with the help of their lawyers. We help try and make sure that that is feasible, and that what they wanted is what is on paper. So this is me. I work at PalliPain. It is my own private office that I started after working in a health system setting for about 12 years. If there's anything I can do to help, or any questions anyone has, or anyone needs anything, you can call me, text me, fax, email. You can take a look at our website. And the day ended as a happy day. So the velociraptor did not eat my daughter. They all had a great day, and we went home happy. I appreciate everybody's attention and time. Thank you, Katie, very much for organizing this. Thank you, Dr. Dutcher, for moderating. I'll turn it back over to Dr. Dutcher.
Awesome. Well, thank you, everyone. Thank you, Dr. Gill. I had a very similar experience with that velociraptor, even though I knew it was coming, and I got so scared. They got me so good. Like, there's the pictures, a sequence of pictures is just hilarious. So yeah, so at any age, that little velociraptor can get you. So just as people are, having some time to settle and think and maybe type in their questions, I'll start off with a couple of common questions that I hear. So a lot of times, as you said, people are, worried about a lot of things, and we have a lot of things to get through, right? I'm just talking to people about, maybe a new diagnosis, and I ask people several times, do you have any questions? And I can see that look in their face, like, I don't even know what question to ask. And sometimes, so, I kind of talk to people a little bit about, well, what worries you, or what are your main concerns? And a lot of times people are really scared about, palliative care or hospice. As you said, they aren't the same thing. And a lot of times people, for example, let's say maybe the patient is, 80 years old, and the family members of that patient who are, maybe their children, or, they're in their 50s or 60s, and they're really worried about their family members suffering. And some of them may think like, well, maybe chemo isn't the right thing for them, or maybe, yes, the doctor said all these things about chemo, but like, well, who's gonna make sure that, yeah, I know the oncologist wants to give chemo or give the treatment, but who's gonna make sure that my dad's still okay with all of this? Can you talk a little bit about that? Like when there's, you know, uh, how you navigate these questions between family members who are, very much trying to be helpful, um, and they want to watch out for their parents, like maybe their parents probably watched out for them.
I think that's a great question because it's something that happens quite often where we don't know what to do, and so the natural reaction is let's just do what we are told is the next step. And so I think having that conversation with patients, especially if so, there's going to be two different avenues, I guess. One is the avenue of looking at it from a patient that is decisional, can understand what's happening and understands what's going on, involving them and the family in that conversation and talking about what does quality of life look like for you? What do you want with the rest of your life? We can talk about treatment options and I love talking to oncologists and calling them and saying, hey, this is the regimen that we're talking about. How sick are they going to feel? Could they potentially feel with this regimen? And having that honesty with the patients and saying, hey, the treatment plan that we have for you, you're not going to feel too terrible. I think it might get you to do okay. Or is it's going to be rough on you and you're going to really feel it. I tell patients that a lot of chemo regimens are like poisons. They knock you down, and our goal is how do we lift you back up from those. But for people who are older and more frail and already having difficulties with things at home, do we have that leeway to knock them down like that? So it's a conversation with those patients and with their families. On the other side of the scale, or the other side of the spectrum, I guess, is patients who don't have decision-making capacity. They don't have the ability to understand what's going on. And that's when we find families that say exactly what you said. They took care of me when I was young. I have to take care of them now. And it's having that honest conversation with families and saying, taking care of them, we've got to understand what is their goal, what would they want if they could be sitting here with us and be completely clear of mind, understanding what's going on with their bodies from a big picture view. Is this what they would really want? If the answer is yes, then absolutely we do it. If the answer is I don't know or maybe, then we have a deeper conversation about it.
Yeah. Another question I get often is, well, I'm already seeing so many doctors, like, why do I need another doctor to do this? And who's going to pay for this? And like, how expensive is it going to be? Um, who can you talk a little bit about that?
Sure.
In palliative care, and then I know this session is generally about palliative care, but maybe if you want to get a little bit into hospice and what payment is like or not like for hospice.
Sure. So with palliative care is generally just like any other medical specialty. So there's no such thing as palliative care is taking over or anything. Just like you
Yeah.
wouldn't say that the GI doctor is taking over my care for the rest of my everything. So palliative care is just another specialty level of care, just like a GI doctor or a cardiologist. So any kind of a specialty doctor, when palliative care is covered by insurances, just like they cover any other specialty. So there's nothing drastically different from a palliative care perspective. Hospice is a very big change to that. Hospice care falls under the Medicare benefit. Or if someone has a commercial insurance and they're not Medicare eligible, most commercial insurances also cover hospice care. Now, the difference with hospice care, for the most part, there's definitely going to be outliers, but for the most part, hospice care is 100% covered by Medicare. And that includes medication, supplies, equipment. The goal for hospice care is providing a family everything that they need to help take care of someone at their homes or wherever or at someone else's home or something like that. But hospice care generally falls under the Medicare the Medicare benefit and is 100% free.
Awesome. Yes, and that's something that a lot of people don't realize is that, hospice provides you a lot of support, and hospice is something that can happen not just in the hospital or not just in the house, but it can be, sometimes people are too sick to leave the hospital, but we can still do hospice-like things in the hospital. Sometimes when people, we have sometimes the benefit of time of knowing, oh, this isn't going to go in a good way, and people can plan in advance and they can say, well, it's really important for me to be at home. I don't want to die in a hospital. And hospice can be really helpful with providing, like you said, equipment and things like a, movable bed, a hospital type bed that makes it much easier for someone to be at home and having the support they need.
Absolutely. And it all starts with that conversation, right? The conversation about goals and quality of life and what that means to patients and families.
Absolutely. And, um, just to, I think one thing that I have found over the years that's very helpful when I'm learning something new or learning about something new is to hear some examples of like, oh, what is this like in real life? And so, as many, we in the medical profession, we see this more often because we see this in the hospital and with our patients. Um, but when we're kind of starting out, it's new to us as well. And so I remember being, a kind of relatively new physician, a resident, and hearing about hospice and having family meetings and being very kind of confused about what it exactly all meant. And I would hear things like, oh, well, there's this study that showed that when you introduce palliative care in addition to cancer treatment, this was with stage 4 lung cancer patients, that these patients actually live longer. And I remember reading that study. That study came out during my training, and I thought, wow, okay, that's kind of surprising. Um, and maybe not surprising now that I look back on it, but at the time, all of my focus and energy and schooling was like, well, really, chemo is what kills cancer, and cancer, the disease is what's going to kill the patients. And yes, while that's true, like you said, a lot of times treatments, um, our treatments also have side effects, and the suffering of those side effects also weighs on people. And a lot of what palliative care does is helping people manage those side effects, and they also know better when to ask questions and when to tell us, my shortness of breath is worse than before, or my this isn't just my cancer pain. I'm dealing with something else, whether it's emotional pain, depression, things that are, of course, not uncommon, and you're dealing with a difficult disease, you're dealing with a difficult situation, and sometimes just talking about those problems, realizing that, oh, maybe there is another doctor I need to talk to, or maybe there's another medication I need to help me with these particular symptoms. So one patient story that I've always remembered is a patient with acute leukemia, which is a pretty deadly type of cancer. It's one of our more, this is a particularly aggressive type of blood cancer. And this gentleman had actually been through cancer before. He had had a different type of cancer, which had been treated probably about 10 years before. And he had done well, and he, was working. And at this point, this gentleman was probably in his 70s, getting ready to retire. And he was diagnosed with leukemia. And the year before, he'd also been diagnosed with kidney failure. And so he was on dialysis. And leukemia, even in a healthy person with no medical problems, the general life expectancy, even with treatment, is about a year. And some people even less. Some people it would be, 6 months. If you don't have any treatment at all, the general life expectancy for someone with acute leukemia is about 1 to 3 months, depending on how bad it is. And I'm just giving this as context. So I met this gentleman in, let's say, August or October, and he wanted to start treatment because he, well, I had got chemotherapy before and I was able to get treated. And he still had, yes, he was getting ready to retire, but he still had young family. His daughter was about to have her first grandchild. So he wanted to be around for more time. He knew he wouldn't be forever, but he wanted as much time as he could have. So we started a treatment. This was a treatment that was a pill therapy. So this was actually a lot easier for him to take and deal with his dialysis. But he ended up having some complications that required him to be in the hospital. And he was in the hospital for about almost a month when we were trying to sort out his dialysis and the therapy. And it's sort of like when we tried to fix one thing, something else would get bad. And so we had a family meeting and we talked with his family and he said, I really just don't want to be in the hospital. I've been here so long. I want to be with my family. And one family member was really, really worried that, well, if he leaves the hospital, he won't be able to get his treatment and he'll pass away. And another family member said, well, yes, that's true, but do we really want, it's so hard to see him and for him to be in the hospital. And even with the treatment, he may still pass away in this short amount of time because of all these complications. Or even the treatment itself may make it so that he has, that he has complications. And so ultimately the family and the patient himself really wanted to, not be in the hospital. And he understood that, I have a limited amount of time, and with my limited time, I don't want to be stuck in a hospital, which is very reasonable. So he went home on hospice, and he was actually able to still get dialysis because his dialysis was not the reason he was dying. It was the cancer. So long story short, I thought, well, this was around November, December, and I thought, well, it's probably going to be, by March or so, I might be getting a notification from his family or from the hospice agency that Mr. So-and-so has passed away. But I never got any notification. And so I kind of kept going. And then, it was March, April, May, June, July. In July, we got a notification that Mr. So-and-so needs to come to visit to the clinic. And I said, wow, yeah, of course, I'm happy to see him. And so it turns out that he had sort of outlived his initial hospice prognosis, and we had to certify that, yes, he still has cancer. And so this was one of those, very surprising to me, but I was so thankful, and gracious that this gentleman lived so much longer, 6 months, without, he had prior treatment, but without active leukemia treatment. And he lived for 6 months. And if I had been trying to keep giving him chemo, he probably would have died the next month. So that really made it hit home for me.
It's so valuable to involve patients in that decision, right? Like having that conversation in the hospital and saying, "Hey, you've been here for a month. This is what we want to keep doing. That's fantastic. Let's keep going. But what do you want? This is what we want. We are doctors. We want to do these things. What do you want?" And it's so valuable to get that insight from them.
All right. So we have some questions from the group chat. I'm sorry, they're only coming up on my phone and not the computer, but it's to talk about how does palliative care work alongside curative treatment? So how do we, talk to each other? Are we, two separate lanes? Do we actually talk?
That's a great question, and I don't. Let's say that they're two separate lanes on the same highway going in the same direction. I am a furious texter, and I will see patients, and I will be out of the room already texting the oncologist. If it's something serious, the text is going to say, "I need to talk to you." If it's not, if it's something that's just symptoms related, I will shoot a text within a few minutes of saying, "I just saw so and so. this is what's going on with them today. These are the medications that I changed. Let me know how they do when you see them. And it goes back and forth because I'll see them one day, the oncologist might see them a week later. And so a week later, I get a text from the oncologist saying, hey, their nausea is still not too good. What can we do? All right, well, let's try this, and this. Or their pain is still 10 out of 10. What can we do? So it is a constant communication back and forth. I love it. I know how busy we all can get, so that's why I always text first. But if it is something where somebody comes to see me and they look awful, I will call the oncologist immediately, or whatever specialty I'm seeing, whether it's a heart failure patient or a cirrhosis patient or whatever it might be. I will call, text, and say I need to talk to you immediately because something's changed, and we don't
Yes,
want to ever treat symptoms that are masking something serious. So we always want to be sure that whatever's going on, we know what's causing that symptom before we try and help with that.
definitely. And I will say I am very happy to speak with palliative care doctors. I routinely speak to them, whether it's patients in the hospital, in the clinic. It's always helpful to have another set of eyes and ears. It's always helpful to have someone who, maybe they mentioned something in passing to me, but they really talked more about it with the other doctor, or, and it's so helpful. Another question from a patient is, for a participant is, I'm struggling with neuropathy after cancer treatment. How would I get started with palliative care? Does it require a referral? Yeah, so
Um,
just call.
Yeah,
You can
most of the time
self-refer.
it is a simple phone call. There are some insurances that require it to be a referral. Most of the time, even if you call, I'm still going to reach out to the oncologist and say, "Hey, this is who I'm seeing. Can you send me some records so I know what's going on? What medications were they on? Is this common for neuropathy related to chemotherapy? Is this neuropathy related to diabetes? Is there neuropathy related to surgery? Is it so? It's again, it's looking at the cause of it and then understanding how can we treat it. But no, I'm always happy, and anybody's from a palliative care perspective is happy to treat neuropathy. Can't ever promise that it'll ever go away completely, but happy to try.
Yeah, and I would say, you can ask your oncologist for a referral, you can ask your primary care doctor, anyone can refer. Um, so yes, and you can even pick up the phone and refer yourself. So we'll work on the back end if something needs to be done through the insurance.
Yeah.
Um, who manages medications with a palliative care team? Uh,
Who manages
well,
medications?
I was going to say generally we both can, but we usually try to pick one person to be in charge. So I'll let Dr. Gill handle.
Same answer. It's a conversation with the oncologist. If oncology is seeing them more and more frequently, I can always say, "Hey, Dr. Dutcher, you're going to see them next week. If you see this, can you make this kind of an adjustment?" It's a conversation. As long as it's a conversation about medication changes, then both teams can do it. But if it's or one person just says, "Hey, I'm just more comfortable with you managing this from now on," that's fine too. It's a conversation.
Exactly. There's definitely, some medications that I'm very familiar with and I'm very comfortable starting, but then there's things that, oh, this is a new version of some medication or a new drug formulation, and since I'm not as familiar with it, I'd rather you see someone that knows how to manage that and what things to look out for. Um, and then just to go back a little bit to one of the previous questions about palliative care during treatment and how we co-manage. Um, a lot of it is, yes, pain medication, pain, nausea, but like Dr. Gill said, there's so much of even nausea that is really like complex. It's not just the physical sensation of vomiting. There's a lot of aspects to it that are about, you know, the smells or even just proximity to things, like how there's people that tell me, I want to eat, I'm so hungry. And then I put something in my mouth and I can't, like my body rejects it, right? Like it just, the taste is, or the texture, Um, so like what are different strategies that you handle in that sense?
So, and it's what I said. Nausea vomiting is my favorite topic because there's so many things, whether it's the tastes, whether it's the smells, whether it's when something gets to someone's stomach, it makes them sick. It could be anticipatory nausea where somebody has had medications or treatments or chemotherapy before, and that understanding that those treatments made them nauseous before, you can actually have a really high level of anxiety to the point where you get nauseous just looking at someone about to get treatment. So there's so many different causes of the nausea. We've always got to look at what it is first, and then we can work on what is our goal in treating it and what can we use to treat it.
Right.
There's a lot of treatments for nausea, but they all depend on what the cause is.
Yeah. There's another question from a participant asking, well, how long can I see a palliative care doctor if, maybe I've already finished my cancer treatment, but I'm still having symptoms?
I don't have a time limit. I don't think there should be a time limit. As long as we know what's causing the symptoms, then our goal is to help keep treating those. The goal is quality of life. That's what we want people to have. We want people to live good, long, healthy lives. And so by treating and focusing on quality of life, there's not really a time limit in how long we have to fix someone's quality of life.
Yeah, absolutely. So there is no time limit, is the answer. Um, until you get tired of seeing Dr. Gill, basically, that's the
Exactly.
answer.
And seeing me every month, it gets old really quick.
Um, I'm not seeing any updated questions. Let's see. But oh, here it is. Are all visits in the office, or do you, Dr. Gill, go to the hospital, or do you do other kinds of visits?
That is also a great question. I am only in an office right now. I've spent my time in a hospital, and I really enjoy being in an office setting. And so for now, I'm only in an office. My office is in Cumming. It's about a mile from the hospital. And then I do have an office once a week up way up north in Demarest, about once a week.
Do you do like video visits or phone visits?
Um, so that becomes a Medicare and an insurance issue at this point. Right now, I'm not doing very many video visits. My general rule that I have for telehealth is if someone is feeling nauseous, sick, in pain, they feel miserable, I want to see you in person. I want to see you
Right.
to see what is it that's going on.
Hmm.
After a certain period, if your symptoms are completely well controlled, you're doing fantastic, and all we really have to do is talk about let's just refill medications, that's when I'll look at telehealth visits. Now, there are limitations in Georgia and by Georgia State in the types of medications I can prescribe via telehealth and whether I have to see you every 3 months or once a year. So there's some nuances to that. But I do telehealth visits, but it has to be once I've gotten to know someone and I know that those symptoms that we were really struggling to control before are now much better controlled.
And I will say I've been to Dr. Gill's office. It's really cool. It's really nice. He has some really cool decorations. Um, so it is way more fun than my office or any hospital.
Thank you. Thank you.
But as a general response, we do have palliative care consultants in the hospitals as well. So maybe not Dr. Gill specifically, but there are other palliative care physicians, nurse practitioners who work with us and collaborate with us at the various Northside hospitals.
Yes, Northside Hospital has a fantastic inpatient palliative care team. I work very closely with them, especially when someone gets discharged and they need symptom support when after their hospitalization. So I work very closely with the Northside team. They're all fantastic. They're all great people.
I've had great experience as well. Um, More questions. So what about something like So I saw a patient today who is okay now, right? Like they're okay now. They just got their diagnosis. They're getting their treatment plan. But I expect they're probably going to have some symptoms or some concerns along the way, um, or maybe even though they're okay now, this is a diagnosis that unfortunately I can't promise to cure it. It's something that will be you'll be living with treatment. You'll be living with this cancer for a while. Um, what kinds of things should they think about, or before meeting with you? Like what kinds of obviously you're going to talk to them, but what are a lot of questions that you get from people?
The biggest question I get is how is this different from hospice care, and what are you going to do for me?
Hmm.
And so it's reminding people that I'm not hospice care. I'm very far from hospice care. My goal is whatever your goal is. It is aligning myself with families and saying I have no agenda out of any of this other than how do we make sure your quality of life is great. Early on in a diagnosis and in a disease state, symptoms might be minimal. They may have very minimal symptoms. And so I really like to at least just meet with them and just say, hey, this is what I can help with if you need me. If you don't need me, that's great too. And that can be as something even as simple as a phone call sometimes, just so that people know there is some support there in case I need it. I'm not going to make people do a full hour visit if they're like, we don't really feel bad, we don't really know why we're here. I'm like, that's okay. Let's have a quick phone call. This is what I'm here for. Call me anytime. Call me, text me, email me anytime.
Awesome. Yeah, I think one of the questions that I get often is, well, are they gonna stop all my medications? Are they gonna, not let me take things? And I say, palliative care does not mean no care. It means helping you with whatever symptoms you're having. And if you have high blood pressure, we still need to treat your high blood pressure. Now, if your high blood pressure medicine is making you sick because you don't have high blood pressure anymore, then yeah, maybe you don't need that medicine, but we're not just going to willy-nilly stop medications.
No, and I don't stop medications like that. I rely on primary cares, cardiologists. I rely on other physicians and that frank conversation with them and saying, is this appropriate or not appropriate? I laugh when I tell patients, you don't want me managing your blood pressure. I haven't done it in 15 years. I don't even know what meds we use anymore. And so I laugh about it and say, that's why we have multidisciplinary teams. That's why we have other physicians available because everybody has their own specialty, and I am definitely not a specialist at primary care, and so that's why we have that
Yeah,
conversation of is this the right medication to continue or not continue?
right. And, we talk a lot about how palliative care is available in different stages of people's illness. And, we talked a little bit about hospice. Um, how do you approach the conversation when people tell you, or I hear this often when people say, well, doctor, I know I'm not doing well. Like I know I'm kind of getting to the end and they're kind of afraid of saying the dying word but you kind of know that that's what they're getting to. Um, how do you talk about something that's so scary and make it, you know, less scary?
We can never make it less scary, right? And um, dying is a natural part of life, and it is having that honest, open conversation with the patient and the family. And a big part of it is the patient, it's themselves. It's tell me what made you bring this up. Tell me why you're feeling the way you're feeling, or tell me why this is now become something that's important to you. And most of the time patients will say, well, I've actually been thinking about it a lot recently, and it's the nature of having an advanced illness. It's making sure that we know we can have those honest, open conversations when we need to have them.
Yeah, I think one of my favorite memories about this sort of dying conversation is a patient who was also elderly. And so we were, he happened to be in the hospital for something, um, but before being in the hospital, he had actually been going on a trip or on a visit with his wife to the cemetery because this was part of their planned, like one of their plans for that week was to visit their cemetery plot. And Mr. So and so was very adamant that he had a specific plan that he wanted for his funeral and specific catering. And this was before he even knew he was very, I mean, he knew he was sick, but he wasn't expecting to be dying the following week, which he didn't. But it was funny because I walked into the room and his wife said, "Oh, just a minute, I'm on the phone." And I said, "Oh, okay." And then he said, "Oh, well, I'm on the phone with um, I said, "Oh, what was it?" "Oh, I was on the phone with the caterer. We're just making sure that, they know what he wants for his funeral." And I thought, "Oh," and I was kind of shocked. And then they told me, "Oh, don't worry. We've been planning this for a while." He was already in his 90s, so he was making sure that nobody else had to worry about funeral planning because he knew exactly what he wanted. So with that, I want to thank everyone for joining us today. I'm not seeing any new questions in the chat, but please feel free to send them to the CSC email, to Dr. Gill's email. We are happy to take questions offline later on. And as um, as as mentioned before, even just the cancer support community website has so many great resources as well. I don't know if we have a couple slides at the end to share about the CSC.
We don't, but if
Okay.
anybody would like more information about Cancer Support Community Atlanta, they're welcome to visit our website. I'll put it in the chat box at cscatlanta.org. And I did put that video link in there, Dr. Gill. So if anybody wants to check out that video, please feel free to do so by clicking the link in the chat box. Thank you, Dr. Gill and Dr. Dutcher, for being so generous with your time and expertise. Thank you to all of our participants. Such good questions to get our conversation going. If you'd like more information on Dr. Dutcher, you can find her at gacancer.com from Georgia Cancer Specialists. And if you'd like more information or connect with Dr. Gill, you can visit him at PalliPain.com. And again, we'll have a recording of today's program for anybody who have missed it. So please feel free to share that with them. Thank you both again, and we hope to see everyone again soon. Take care.
Thank you.
Thank you, everyone. Thank you, Katie. Thank you, Dr. Dutcher. Appreciate it.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org. Or follow us on Facebook. We'll be sharing additional information on upcoming programs.